Good evening, everyone.
Sit down.
Welcome and thank you for coming out this evening. My name is Dr. Steve Butler. I'm the Chief Executive Officer of St. Genevieve County Memorial Hospital, and I've been here for the last 3.5 years. I've been here a little bit longer than that in my earlier life. I'm about 15 miles away from the farm that I grew up on in Ellis Grove, Illinois, so the area has always been familiar to me. I use the honorific of doctor. It's a doctorate in medical ethics, health policy, and law. So I'm not a physician. I didn't want any confusion over that. So we want to thank you for coming out tonight. Mary, if you would advance that slide. So this evening, we want to talk about a few things that are going on at the hospital. And I want to welcome Randy Rizika, our County Chair Commissioner, Rod Shear, our Hospital Board Chair. We've got Bruce Giesler from the board, Mark Fowler, who's on the board. Do we have anyone else who's elected? Okay. A couple of things about what we're going to do tonight. So this isn't intended to be a forum if there is a concern about patient care that had happened recently or not so recently. I can't talk about the particulars of a patient situation. If there's a personnel situation of someone that, if you want to compliment a nurse, that's great, who took great care of you. We have a lot of those. If there's a concern about that, this really isn't a forum for that. So there's stuff we can talk about and stuff we can't talk about tonight. If there are concerns, I'm happy to talk with you at whatever length you need during regular business hours at the hospital. So with that out of the way, a couple of things. Our message here is independent status is a priority of the board. I've heard a lot of different things about what's happening and what's not happening, and what is happening is the board is still laser focused on trying to make this a community hospital that's responsible to you here in the county, and now and for the future. And so the idea that we're talking with another organization looking towards lease management, any other change of control is just not happening right now. The other stuff that I really want to talk about is that rural healthcare is changing and we're growing to serve. There's a lot of things that are happening, and I want to give you a perspective on what's happening with rural hospitals nationally, what's happening in rural healthcare particularly, and what's happening with our hospital locally. And the fact that I'm going to ask you for your continued support in a couple of different ways. So we'll talk about that as we go through the evening. And if there's time and if there's interest, I guess we can ask questions. We didn't have a mic set up specifically for that purpose. But if you ask me questions and I understand them, I'll restate them into the microphone so everybody else can hear them as well. So next slide, please. So a little bit of an introduction to St. Genevieve County Memorial Hospital. Maybe you've been coming to visit our physicians your whole life. Maybe you just moved to the county. Maybe you just noticed that we put different colored lights during holiday seasons. There's a whole variety of ways that you encounter the hospital. And so I want to give you a little bit more background about the hospital. Our mission and goals, board member responsibilities. One of the main reasons I'm doing this is because we are going to have a board vacancy coming up. I'll talk about that a little bit. And there are a couple of people running for board election. Now, this isn't a forum for candidates to give speeches or anything like that. I have to stay well clear of that kind of activity because it's up to you to decide who sits on that board, not me. So I want to be clear on that. Some things about the national health industry. Hospital operations and finances, connections to the community, where we're going as an organization, and some things that we do that a lot of hospitals don't. And so I want you to be well informed of that. Just in general, the presentations I've been making last about an hour. So I don't know how that affects your dinner time or feeding your cat or whatever else you may have, but that's my intended timeline, just so you can know what to expect. So next slide, please. So our mission is we put people first by providing excellent, personalized, and compassionate health care. And then this particular evening, we're putting you in the community first. So every day we strive to take great care of patients, and as the administrator I try and take great care of the employees and physicians who take care of the patients. That's my role in life. And tonight we want to put you first. So next slide, please. So I called out some of our board members who are able to join us tonight. And when we look at them, we've got a great, highly experienced, very interested and involved board. And I'm really grateful for their service. Rod Shear has been on almost 39 years and has served as chair for almost that entire length. Mark Fowler, who's here tonight, has served almost 25 years. It will be 25 years this spring. And he's decided not to run for another term on the board. After 25 years, I think he's had his turn and he should be able to decide whether he wants to continue or not. So we appreciate his service. Kurt Bosler has been on close to 20 years. Veronica Charlo has been on more than 15. And Bruce Giesler, who's here tonight, has been on the board almost 4 years. But he'd also had a lot of service on the Friends Foundation board beforehand, and we appreciate his continued commitment to the hospital. So next slide, please. In terms of leadership, we try and stay behind the scenes fairly often, but I do have several members of leadership here this evening with us. So if you raise your hands as I call you out, there's myself, back when I was a little less fuzzy, on your left. John Schmidt, who recently joined us, he's got a lot of experience in healthcare, has a CPA, 2 master's degrees in health administration, and MBA. Jennifer McBride Hobbs, our chief nursing officer, who is native to St. Genevieve and is several years in nursing administration before coming back home. Sherry Hamby Vance, who's got a great deal of experience in human resources and is fairly new to healthcare, but she knows the federal rules and regulations better than anyone we've had work with us before. Herschel Parker in quality and risk. Herschel has been with us for almost 20 years. Just about 20 years. And Allison Richmond, who's in charge of physician services, has been working with physicians and physicians groups, much larger physicians groups usually, for about 15 or 20 years as well, so a very highly experienced group. And I'll just mention that I was a bedside nurse for about 10 years before I got into administration. I've been in administration for 30 years, and so I am committed to small town healthcare. Next slide, please. Some of these turned into eye charts a little bit, and so I'm going to send the slide deck to the local TV station so that they can have that as well. The point here is that this is a hospital that has never sat still. From the very beginning, it was built in 1969, and as early as 1973, there was a need for growth and expansion. And so there's been that continued tradition of meeting the community needs, looking at what the community needs, and then changing the physical structures in this case so that we can be ready to take care of all the physical and healthcare needs of the organization, from a hospital to including oncology space, Bloomsdale Clinic in 2001, the first one. We took on Riverview at the Park for a few years and then found private owners for that. ER additions, Apple Kids, the front lobby remodel in 2008, a new emergency room, 2020, the new medical surgical and Pine Drive clinic expansion. It's a beautiful space, and we're very fortunate to have that legacy of wonderful space to do our work in, and we're going to continue to plan for what we've got going forward. Next slide, please. A little bit more about trustees. So in the handouts in the back of the room, it talks about the American Hospital Association. That's kind of my professional organization, and they have a lot of information that helps trustees do their work of overseeing and guiding hospitals. And I've got some materials in the back that you can take with you. But from when you're looking at who the trustees should be elected now and in the future, there are three main duties. There's a duty of obedience to the charitable purpose. So what is it we're here to do? And in this case, it's to provide health services to the St. Genevieve County. That's what we were formed for, and that's what they've stuck to very carefully. A duty of loyalty to act in the best interest of the hospital, and a duty of care to be diligent and caring. So preparing for board meetings, talking to folks who are in the county to make sure they understand what the perceived needs are and to help pass along information. Next slide, please. And the role of the board is to govern, not manage. So we do have professional managers here, and I pointed them out this evening. But the board is to oversee and make sure that we stay on point and on track and make sure that we're meeting the needs of the community and not just a small segment, or not just looking for, are we going to hit quarterly gains? Or are we hitting millennial milestones? I guess you could call it that way. So they establish the ends and goals and make policies and decisions. Should we expand a clinic? Should we add more physicians in a particular specialty? It's those kinds of policies, as opposed to should lunch be from noon to 12:30 or 12:30 to 1. So I'm very grateful to the board for keeping that perspective. To oversee performance and exercise accountability, so holding administration to task, and they do that, I assure you. And building relationships with the organization's key stakeholders, and that's why some of them are here tonight, and I think some more of them will be here next week as well. So everybody's schedules don't always line up. So the next slide, I'm not going to spend a whole lot of time on this, but it's in that packet that's available to take home with you today in terms of some of the responsibilities of the board. So next slide, please. I love showing off these pictures of our staff and physicians. I think it's such a great group of people to work with, and I really feel blessed to be able to work with them. And so we're going to see some more pictures of them, and I hope you got one of our calendars, because it's a really great calendar. And I think Tina can probably scare up a few more if you don't have one and would like one. So next slide, please. When we look at the overall health status of St. Genevieve County, so these are some rankings from the Department of Health, and they are lighter. The lighter the county is colored, the healthier the county is in terms of health rating. So you can see St. Genevieve County is rated very light. So I know you know where it is, but you can see how light the coloring of St. Genevieve County is compared with other counties. That's because the folks in this county have a pretty good approach to their health care. So next slide, please. When you look at health outcomes, we're even better. We are in the top 25% of all Missouri counties in terms of healthy outcomes. Honestly, even things like COVID had a less severe effect in St. Genevieve County when you look at the surrounding counties, and you can see why, because their overall health is not as strong as the overall health of people in St. Genevieve County. I can't entirely describe where that is. Maybe it's the clean living, maybe it's the overly sausage. I'm not entirely sure, but something good is happening here. And it's our job as a healthcare institution to promote and support and maintain that as much as humanly possible for you. Because one of the things I told the board I want to do is have healthy lifestyles for generations to come starting today. And that's something that I challenge our staff with, and that we need to continue. And I think you're already well on your way towards that. So next slide, please. Even when it comes to things like drug overdose death rates, even though the opioid scourge is going on, there's still over 100,000 people a year who die from opioids. And in the U.S., when you think about it, that's almost the deaths of twice the deaths of the entire Vietnam War, the entire 15-year war. And 100,000 people a year are still dying from that. Here, we're a little fortunate. We stand out as a place where we have less incidence of drug overdose deaths. I think that's due, at least in part, to the work of some of our staff, because they've been very diligent. The pharmacists on our staff have been very diligent about watching prescription drugs and quantities and everything that goes into prescribing an opioid drug. Our pharmacists have been very scrupulous about that for almost 10 years now. And I think that's to their credit, and I think that the effect is what you see there. Next slide, please. On the scarier front, when you talk about the pressures on small hospitals, they're considerable. And I'll get into some of the sources of them as we go through. But since 2005, so in general, there are around 5,000 hospitals in the U.S. total. There are somewhere around 1,500 to 2,000 small rural hospitals like ours out of that cohort. When you look at it, almost 200 of them have closed since 2005. So the financial pressures are very real, and I'll get into some of the reasons for that. Next slide, please. What happens when a hospital closes? You lose access to health care, that's obvious. You lose providers that depend on the acute care hospital because, for example, surgeons don't stay where there's no hospital to do their work. It's as simple as obstetricians don't stay where there's no place to safely deliver babies. There are direct costs. There are loss of jobs from the largest employers in town. Many towns that have a hospital close lose their major employers because their employees want to be close to a hospital. Many retirees leave because they want the security of being near a hospital. And indirect costs, increased travel costs for poor, elderly, disabled, and other patients. So if the hospital closes down at a small town, then older, sicker folks have to travel farther for any hospitalization. And it is catastrophic for them. And then if they're lucky enough to have children living nearby, they have to take off work for every incidence of care that's involved, maybe a day, maybe 2 days, maybe stay overnight in a bigger town where they don't know anyone and where everything is unfamiliar. So those are pretty scary consequences. Next slide, please. When you look at the financial challenges, there are a number of them. So for all our gumption and all our energy, we do get lower reimbursements than other hospitals. We don't have an economy of scale. If you have someone that says, I have a book of business with United or Aetna or Cigna or Blue Cross, and we treat 200,000, 300,000, a million people on your plan per year, you have negotiating power that we don't. It's really simple. There are minimum costs to continuously run inpatient services like the emergency department. As I'll get into in a little bit, we have usually about 15 people come into the emergency department per day, but we have 2 RNs on 24 hours a day, and we have a physician 24 hours a day in that space. Now that, from a hospital perspective, is not very efficient, but when it's my turn to come into the ER, I want to make sure there's 2 RNs available in case I have something really bad going on, and a physician who's right there waiting for me. That and obstetrics is another area where we do 10 to 15 births a month, which is not bad. But that means that we have 2 RNs in labor and delivery 24 hours a day, 365 days a year. Because what happens if an expectant mother comes in and she's more than 20 weeks pregnant, and she's coming in with things that may be stomach cramps, maybe early labor pains, they go straight back to labor and delivery because those nurses are specially trained to assess pregnant women to see if they're in danger. And so that's why we have to keep them immediately available, because they may have more training than the ER staff for that particular need. And those are just national standards. That's not something peculiar to us. Bringing in new technology is especially costly. Most big systems will not bring in a piece of equipment unless they plan to overuse it. And we have to bring it in often because we know we're going to need it if we're going to keep patients available locally. Rural areas have a population that's often older and sicker than urban places, and with 5 or more comorbidities. So that could be congestive heart failure, high cholesterol, prediabetes. Add a couple more on there, it's not hard to. Then your costs are likely to be 100% or more higher than someone with fewer comorbidities. So next slide, please. And as we mentioned, small hospitals are at particular risk. Nationwide, 191 hospitals have closed since 2005, 15 in Missouri. So that's a lot. Of 161 licensed hospitals in Missouri, 67 are rural, only 28 have OB services. So we have a fully staffed OB service, which is unusual for a hospital this size. We have a lot of specialists that hospitals our size just don't commonly have. And 31 are critical access hospital. So critical access hospital is a category we're in, and that means that 25 or 30 years ago, Congress realized that Medicare doesn't pay the full cost of providing care to Medicare patients. And so for smaller rural hospitals, if we keep our bed count below 25 and our average length of stay, so the number of days you're in the hospital at less than 4 days, then there are some payment advantages to small hospitals like ours that they can settle up at the end of the year to help make up the difference between what they pay and what it costs to take care of Medicare patients. It doesn't close the gap all the way, and they've reduced the payment over time, but it's still better than if we were trying to have the same category as, for example, Mercy Jefferson or Parkland or any of those other places like that. Bigger hospitals have a different payment mechanism. That's really what that means. And then you look at local hospitals with affiliations, and I'll have a map here in a second, but Madison Medical Center in Fredericton is aligned with SSM. Parkland and Bonne Terre are combined together as one hospital, more or less, and they're under BJC. The former Perry County Memorial Hospital is now Mercy Perry. Southeast Health in Cape Girardeau is now, I didn't catch the name, but it is fully integrated with Mercy. Washington County Medical Center is Mercy. St. Francis and Iron County are independent, but Iron County is starting to look for a partner. Next slide, please. When you look at independent hospitals in Missouri, I'll just point out something. There are very few independent hospitals on this side of the state. Most of the ones that are independent are on that side of the state. The systems in St. Louis matured and developed, and I'll use the word metastasized, growth over overwhelming smaller hospitals faster on the east side of the state than the west side of the state. And so there are a lot fewer hospitals that are still independent on the east side of the state compared with the west side of the state. So that's my sense of it. I worked in the hospital in Sedalia for a few years back around 2000, and I think that those dynamics are still there. So next slide, please. When you look at our particular service area, the people who come to us the most are from the 3 zip codes of Bloomsdale, St. Genevieve, and St. Mary. And so that's why those are particularly faded out. It's those zip codes. And this other part of St. Genevieve County, there's about 2,000 people in that area, and they tend to go towards Farmington for most of what they do in their daily lives. So they don't come our direction as much for healthcare either. As an administrator, I've got a cold milk rule. If you can go to a town and grocery shop and get home with the milk still cold, you'll go there for your medical care. And I've seen that play out in a lot of different places, and it's consistently pretty true. So when you look at this map, I won't count Randolph County, but you've got Mercy Perry, Mercy Jefferson, BJC, Mercy. Iron County is hanging on their own, and then SSM, and then down in Cape Girardeau, Mercy Hospital there. So we are about the only hospital in our area that is still independent and still able to stay independent, and that's what we're working towards, is to maintain that independence. Next slide, please. So even though it looks like we were healthier generally on those slides earlier, our county is a little bit older. We are the gold bar on top, and then the blue bar in the middle of each row is Missouri, and black bar on the bottom is the U.S. generally. So what that is going through the youngest age demographic, then 18 to 44, then 45 to 64, and then 65 plus. And when you look at those bottom two sets of numbers, you can see that in our county, like in most rural counties, the older population is greater here than it is other places, which means people here are more likely to need more medical care than people in other places. So that is what motivates us. Next slide, please. When you look at declining revenue, we talked about the hospitals that closed. 40% of rural hospitals have a negative operating margin as of in 2023. And right now, this year, we are one of them. So we have a negative margin for the first time in several years, and I'll give you some more details on why that is. Labor and supply costs, now these are national numbers, not ours. Labor and supply costs have increased more than 20% since the pandemic. Contract labor charges exploded. So there for a while we were having to get agency nurses and other staff in because our staff was falling ill or they were going to work for a travel agency. And so we got lucky. We didn't have to pay $250 to $300 per hour for nurses like some small hospitals did. But we were paying more than $100 an hour for nurses to come in and work here for a while. We've reduced that to just one or two, which is pretty common for small hospitals. But you look at that labor cost, it's extraordinary. Even our regular labor for our employees has increased more than 10% when you look at the last 3 years. But when you look at what insurance companies are offering and what Medicare is paying, Medicare is only increasing what they pay us by 2 to 4% per year, and the commercial insurance companies are only increasing by about 4% per year. They're charging you 15 to 20% more. They're only giving us 4% more. So I'll let you figure out the math on that one, but I know that we're not getting it. So the total expense per patient has risen about 22%. And from Medicare, our biggest source of income, it's only raising 2 to 4% per year. It's just not keeping up. We have had a couple of other extraordinary circumstances. I don't know if any of you have heard of the 340B pharmaceutical program. There is a federal program that lets small hospitals bring in pharmaceuticals and even partner with other local pharmacies. So we partner with CVS and we partner with Country Mart here in town, so that we get a price break, and then we give a lower overall price, but we get to keep a little bit more of that that gets charged to the patients. But manufacturers can say, oh, not this drug, oh, not this drug, oh, not this drug, and pull a lot of drugs off the market that are commonly used. For that line item alone, we have $900,000 less income per year based on manufacturers saying, you can't use this one, you can't use this one, you can't use this one compared to last year. That's a pretty steep decline in revenue on that. In another circumstance, we've had some employees with some extraordinary medical circumstances, and I don't want to cast aspersions on them, but the reality is that between November and December, we ended up having employee health expenses of $1 million between those 2 months above what we had budgeted for the year. So we budget for $500,000 a month of employee health expenses, and we had $1 million extra in just those 2 months alone. Those are some pretty hard hits for a small hospital to absorb, even though we have good revenue. So those are some examples of why we've got a negative operating margin for this year. What I can tell you is that thanks to good decisions made over a long period of time between prior administration and our board, we do have reserves to weather the storm right now. So we're not in any peril of bankruptcy or anything like that. We can continue on as we are. I just wanted to let you know where the pressures are coming from, and we're going to talk a little bit more about what we're doing about it in a few minutes. Next slide, please. And critical access hospitals are more likely to get bypassed. So the perception of ambulance crews of, oh, they can't take care of this patient here, or someone thinking I need to go to where my specialist doctor is in St. Louis to go to the emergency room. Those are some reasons why people bypass smaller hospitals, even though we have a very good rating scale and a very robust panel of physicians. Next slide, please. Next slide, please. That's the Apple Kids crew there. When you look at what we have for medical services, so this is just on the medicine side. In the hospital, we have, as I mentioned, the emergency medicine doctors on call, available 24 hours a day. Obstetrics, Dr. Hannah Kurtz came back here. She grew up here and she came back. We're very pleased with that. And Dr. Mary Bakor has joined her. Transitional care. So a lot of folks, even if they have a case of medical treatment that can't be done here, for example, a cardiac bypass graft or a stroke that needs a lot of intervention, they can still come back to our hospital for the rest of their care and rehabilitation. And some people come back and they come back for their antibiotics, or they come back for the rehabilitation. Up to 6 weeks is not unusual for someone who needs that kind of care before they can safely go home. Cancer treatment and research. So Dr. Liss brought out cancer treatment and research many years ago, and we still keep up with some of those final stage of cancer treatment. So it's almost ready for market. It's been proven safe and effective, and they just want a bigger group of panel of patients to demonstrate the effectiveness. And so that's what they'll use. Sometimes, most of the time, Dr. Stein will use standard medications, but he comes out from Missouri Baptist, and we're very fortunate to have that here. But outpatient diagnostics, including diagnostic imaging, lab, 24-hour respiratory therapy department. That's unusual for a small hospital like this. Several clinics, I'm going to demonstrate those. Primary care, we have a lot of visiting specialists, and we've got the list of the specialists available for you in the back of the room here. And cardiopulmonary, including full-time cardiologists. That almost never happens in small hospitals either. Next slide, please. Then when you look at surgical specialties, we have a lot of surgical specialties, including a lot of them full-time that don't normally live in small hospitals. We've got 3 general surgeons. Dr. Cavins mostly specializes in breast, and Dr. Charlo is doing more and more gastroenterology. And Dr. Salim is a new general surgeon who recently finished his training in Mayo, and so he's joined us this summer. Orthopedics, we've got the group from Farmington that comes out and is doing more and more surgeries, and then doing surgeries they didn't used to do here, including shoulder surgeries. Podiatry, Dr. Martin's now full-time with us. Gastroenterology, as I mentioned, urology. Dr. Enger comes out, and we have 2 full-time nurse practitioners here that do urology clinic. Ear, nose, and throat, ophthalmology, and pain management. I didn't want to mess up spelling ophthalmology and have someone call me out on the slide, so let me say that. And then, next slide, please. What are some of the financial effects? So we have 365 full-time equivalents, but we have a total of over 500 employees on the roster right now. So that's a lot of folks. 19 full-time physicians, 26 full-time nurse practitioners. The county tax support is just over $1 million a year typically. And I think if you did it per capita, that'd be, I did the numbers earlier today, it'd be about $50 a head if we did it on a per capita basis for the county. Foundation support, I'll call out Tom Cavins, who recently joined the foundation board. Thank you for joining us this evening. Over $280,000 last year. That's a lot more than they typically do, but they really came through for us last year on some extraordinary needs. And net revenue of $68 million. The salaries of $28 million. So the hospital went away. Imagine what taking $28 million in salaries out would be. It would be a profoundly negative effect. And so when I look at my job, it is first and foremost taking care of the patients who need their health services. I'm still a nurse at heart. As a business, to be a good steward of the resources I have, and also looking to the future of the community and looking at what these people do, and they live and work and play and worship here, and what they do for each one of you and what they're ready to do. Sorry, I swerved off there. As I mentioned earlier, Medicare is still the bulk of our payment at 52% of our net revenue. Medicaid is less here than I think any hospital I've ever worked at, about 10%. And charity care, just over $250,000 a year. It is extraordinary that it would be at that level because people have employment and insurance here, unlike most places I've seen. So, next slide, please. When you look at our routine, a day in the life of St. Genevieve County Memorial Hospital, our daily census is about 12, so there's about 12 people in beds, and we have about 25 beds available. Births last year, so these are all last year's statistics, 153 births. We had 5,000 ER visits. We had 3,000 surgeries, and we had a big increase in surgeries last year, and we're still continuing to grow with the number of surgeries we do here. 158,000 lab procedures. Makes me faint just thinking about having all that blood drawn. And 30,000 imaging studies. So, next slide, please. When I look at this, our goals are centered around being safe, effective, and connected. So, safe for our workers and a safe place to get health care. Effective, making sure that we always do what's needed for the patient. We always give the best care possible. And connected between our caregivers and our patients and our employees and each other and the hospital and the community. And so this is what this outreach is for tonight. So next slide, please. And our goals are focused around, when you get into goal statements, our goals are focused around patient satisfaction, employee retention, safe environment, and financial outcomes. So patient satisfaction, if somebody gets great care, they tell 2 or 3 people. If they don't like the care they receive, they tell 10 people, and they go on Facebook and tell everybody on what's up on St. Genevieve. I think this morning we had a glorious illustration of people who were unhappy with the business, and I'm trying to do that. I want to build confidence. I want people to be happy with the care they get. I want them to feel well cared for and listened to. And so that's what we're doing with our employees. With our employee retention, keeping our great local employees and preparing them for future success. And I'll call out a couple of people with that. So I'm thinking in particular of a nurse aide. Well, she's now a surgery tech. She started out in housekeeping and kept pestering me, what can I do to get into patient care? And I said, well, let's get you your certified nurse aide license. We paid for her to get her certified nurse aide license. She worked on the floor for a while, and she said, I want to do more. And so now she's in the OR training up to be a surgery tech. There's other people like that. There's another person who started in food service and kept pestering me, what can I do to be with patients? And so she's been a phlebotomist for the last 2 years and is absolutely loving her job. So we want to grow our own as much as possible. Many of the nurse practitioners we have now started out as registered nurses on the floor. And so we want to continue to build that up. People who are already here have a reason to stay. And so we want to make the most of that and help them stay and help us to help them serve their community. And we do have good retention. So our retention is about 83% this year. Most small hospitals are somewhere between 50 and 75% retention. So think about that. You don't know your team members. You don't know if your shift is going to be staffed. And you don't know the skills of the person working next to you when they come on board at first. Those are some really powerful reasons why we want to keep the people here who are already here and well trained. Safe environment. We want to protect our patients and workers. When I got here, I found out that we had a statistic, we had about 60 patient and employee falls the year before I got there. And so that's harm that we have to avoid. So we've been doing things like taking obstructions out of parking lots, posting more signs, putting more places to distribute salt, training up our staff about equipment and supplies, doing everything we can to encourage a safe environment. That's just one of a number of things, and we've reduced that number by more than half. Gravity is still in effect, and we can't rule it out altogether. I think if you saw the icy patches we had just a week ago, you know that we can't entirely avoid it, but we're doing our best. And of course, financial outcomes, we track financial outcomes, and we've given some of those results as well. Next slide, please. We are looking to the future as well. We're growing new physician practices, so we've brought in 8 new physician practices since I've been here. And some of them are to replace folks like Dr. Raju, who after only 40 years here decided he just had to retire. So we have brought in several new internal medicine, family practitioners, new general surgeon, 2 new OBGYNs, new orthopedic surgeon. So we're trying to keep up with the needs of the community. New computer software. Everybody loves computer software upgrades. Well, maybe not. Maybe love isn't the right word. We've got some staff here who are looking daggers at me right now. But we do have to upgrade our software from time to time, and we're in the middle of that right now. And you're going to hear some more in the near future about how we can prepare for that. Careful attention to revenue cycle and expenses. That's something that is really important. We want to make sure that we're getting paid fairly for the work we do. And that's not always the case, and even when it is, the rules keep changing on us. So we need to keep preparing for what comes next in terms of hospital payment. And as I mentioned, the growing practices. The master facility plan, there's been improvements and expansions and remodelings all through the hospital's history, and we're planning for a next round in the best way to serve our community with our facilities going forward. Next slide, please. Some of what has been happening over the years is all the different places you can seek care as part of our organization. And I think we're going to try and do an improved job of letting people know where we are in the community. So obviously the hospital is our flagship, and there are other places that we have, including the Bloomsdale Medical Center. It's a beautiful building just off Highway 55 in beautiful downtown Bloomsdale. Nothing on that? I'll put it to sleep already, okay. So Bloomsdale Medical Center. Pine Drive Medical Center, so the new medical surgical wing is on the top floor of that building, and the medical clinic is on the first floor along with the retail pharmacy. We also have a retail pharmacy in Bloomsdale Medical Center. Apple Kids Medical, that we have several specialists also working out of that clinic. Point Base, we've got family practice and specialty care there. The walk-in clinic, now we call it a walk-in, not an urgent care, because urgent care is trying to charge you emergency room prices for clinic level care. And so you pay a clinic copay and deductible, not an emergency room copay and deductible when you go there. I'm glad that that decision was made a long time ago, and I think that's fair to the community. And then the Charlotte Surgical Clinic as well. I'm going to call out the mayor. I called out the other elected officials, so thank you for joining us, Mayor. We really appreciate you coming along for the ride. Okay. So we do have future plans, and we are looking at what we can do in terms of upgrading our surgery and our other clinic spaces. The green tiles that are on the surgery walls now are the same as when Captain Kirk took the Enterprise out for the first time in 1969. So everything has to change from time to time, and we're looking at the best way to upgrade those spaces and remodel and keep going. Next slide, please. And to the point, I'll give a little infomercial, and we are a hospital, we are clinics, we are home care, and so much more. No, there's not going to be any Ginsu steak knives here, but there are a lot of other things. We do try, I talk about being connected with the community, and this is the backpack handout before school starts every year. They're about, in cooperation with other community partners, we hand out about 200 backpacks every August to make sure the kids have what they need to learn. Next slide, please. The Food is Medicine program. Ignore the Lay's potato chips in the front of the car. That's something that we've been doing off and on for a couple of years. We seek grant funding for that. But the idea is we're trying to take care of people before they get severely ill. In this case, you can watch your markers towards diabetes increase over time if they're not going the right way. And so what we're doing, particularly with Ricky Schaefer in Bloomsdale, is she will get together with a small group of patients individually and then as a group, and then do education about what diabetes is, what they can do to change their trajectory, eat right, sleep right, get exercise, and comply with their other medication regimens. Then we also teach them how to read food labels, how to shop the outside of the grocery store to get the healthy food, not the inside of the store where the Cocoa Puffs are, that I really like. And so we also teach them how to prepare the healthy foods, because if we just go up to someone and slap a zucchini on the table and say, here, eat healthy, good luck, there are a lot of people who are going to say, okay, this is cute, but I don't know what to do with it. So we do teach them how to cook healthy foods. And in those groups of patients that we've done, we've been able to reduce their markers towards diabetes. Even one woman who is actually living out of her car for the entire 12 weeks of the program, her life circumstances were such she was comfortable and safe, but she was still living in her car. We were still able to bring her diabetes markers down into a safe level. I think we helped her find another place to live. But a lot of people can do things to make their health and their lives better, and we want to keep doing that. Next slide, please. Parish nurse program. So this is something that's been in effect around the country for 20 or 30 years. We're starting to do that here. So St. Genevieve Catholic Parish is probably the largest voluntary organization in the community. And I knew that we had a ready supply of retired and semi-retired RNs who are available to help us with that. Once you're a nurse, everybody knows you're a nurse. Everybody asks you health-related questions. I wanted to take advantage of that. And so we started out with taking blood pressures after Sunday Masses. People come up and get their blood pressures taken. And there were a couple of people that came up and they said, you might want to see your doctor tomorrow. And so they're seeking care beyond that. In a few weeks, we're going to do another round where we're going to have people bring in all of their medications and make sure they understand what they're taking. So many things come up, like, this is the same medication, but this is one that's expired, and if you take both of these at the same time, then you're not going to do well. And people just don't understand it. When you get new medications, you often feel rushed, and you don't know if you can afford it, and you don't know when the medication isn't good anymore. And sometimes even things like some of the food supplements you take can interfere with the medications that are prescribed. And not everybody knows that. And if you forget to tell your doctor, you're doing things that don't help your health, and you don't even realize it. So it's things like that. In the last parish nurse meeting we had, we were bringing it open to other congregations. So there was someone from the Presbyterian Church, someone from the Baptist Church. So we want to open that up over time. We're just getting rolling on that. We want to open that up to more congregations, make connections before they need to go to the emergency room, get them the lowest level necessary care so that you stay healthy. As a small hospital, that's my best bet. I want people to stay healthy. I don't want them to get sick enough to have to go to one of those big hospitals in St. Louis. Next slide, please. The walkable community. All these things are not just us. It requires partnerships. So it requires the church. It requires St. Vincent de Paul. It requires the grocery stores. I forgot to mention with the grocery store, one of the things that we did was we prescribed 2 fruits and 3 vegetables. And then we worked with Country Mart to deliver that, and with St. Vincent de Paul to fund it. And so people actually had the direct means to get a hold of that. Anyway, with the walkable community, we're working with the city, we're working with National Park Service, we're working with the county, and we're making getting the sidewalks in town fixed a priority so that it's easier to do healthy behaviors like walking around town and getting walking paths to our National Park Service sites so that people can enjoy the history of the community even more. And with our own employees, the walkway you see there is between our main employee parking lot and the hospital building. And Dr. Charlo said that he heard all our nurses over saying one morning, I almost got hit crossing the road this morning. Well, they're wearing these fashionable dark clothes, which is cool, but they're crossing the road at 5 and 6 in the morning when there's, it's not very well lit there. So we worked with the city to paint the stripes and get the little thing in the middle of the road and a lighted flashing sign so people can cross safely. And I hate to say it, I hope it's not intentional, but that middle of the road sign has been knocked down 3 or 4 times, including earlier this week. So our maintenance crew is having to keep up with that. I don't think that's just on Cataract Day. I think there's some more work. Okay, next slide, please. And the rural parish dental van. So the Archdiocese of St. Louis has some outreach programs, one with medical clinic and one with dental clinic. And so we're partnering up with them. They're coming out to the Bloomsdale Medical Center once a quarter. And so the way that works, they have volunteer dentists. They make long appointments with patients, so they vet them if they need charity care. If they can't afford to pay for the services, they don't want to interfere with dentists who have paying customers. But for people who can't afford it, our physicians can't fix an infected mouth. I mean, you can give antibiotics, but at the end of the day, if it's an infected tooth, they're not going to be able to fix that unless they get proper dental care. So we're working with the Archdiocese. They bring in a van once a quarter. They'll come in and they'll do all the care necessary to take care of that patient the day they come in, so they don't have to come back for multiple trips. And so that's just another partnership. We can't do this on our own. We need partners to do all of these different pieces of care. And so this is one more partner that we have, and we're very pleased to work with them. Next slide, please. So our commitment, the board has made it real clear that they're committed to independence. We've recruited 8 physicians over 2 years, and we've got other growth in services. We're bringing on new services as we can. We're upgrading our computer system. Meditech is the name of the computer system we use. We're committed to our future by continuing to update our facilities and preparing new providers, new services, new procedures, and bringing on new tools. And committed to our goals of safe, effective, and connected care. Next slide, please. So we are going to ask for your support. It can come in a number of different ways. First of all, please choose us for your care whenever possible. It's not always possible, but we have a great number of modalities of care. And reach out to us if you're not sure we do it locally. One of the things that happens is you get a symptom, you go on the internet, you check with Dr. Google, you see somebody else's ad, and you say, I think I'll try them. Ask us, ask your primary care provider if we provide that locally. If you think there are services we should offer, please contact me. It may be that we already offer it, it may be it's something that we're getting ready to offer, or it may be something that I hadn't thought of that we should consider and bring to the board. Please support our fundraising efforts, our Golf Classic, our Ride to Survive, our Gala, and auxiliary events. And financial donations are used to support new facilities, equipment, and patient care, so we're always ready to take care of you. Next slide, please. And with that, with the partnerships, we have great groups, including the Friends of St. Genevieve County Memorial Hospital and our auxiliary. The Friends is more of an external group. They reach out to the community to ask for support that way. So it's a 12-member board. They sponsor the Gala, the Ride to Survive, the Taste of St. Genevieve County. We deferred that this year. We had a turnover in directors of the foundation, the administrative director, and we do have one selected. Her name is Terry Thomas, and she is already a hospital employee, so we will be transitioning her. Her mother was Rita Brufeld, and I'll brag on her a little bit. her mother is the one who won the essay contest in 1964 of why we need a hospital in St. Genevieve County. So she has a multi-generation commitment to our success, and I'm sure that she will do very well. Anyway, and they've donated over $1 million since founding. The auxiliary is more of an internal volunteer group. I think everybody knows what a hospital auxiliary member is. It's a very common idea. Over 160 total volunteers, 55 of whom are very active. They do greeter, gift shop, and they have quilters at the hospital. A lot of internal events, a lot of chocolate sales. It's undermining my ability to keep my employees healthy with all the treats they bring in, but that's okay. Everybody needs a little bit of fun. They're friendly, engaging, supportive to patients, visitors, and staff. Typically over $25,000 a year, so this year they're buying a new birthing bed for OB. And new bassinets. Apparently we were using the original bassinets in the newborn nursery. We got some really slick ones now. And last year, 10,200 hours donated, a $292,000 value by Missouri volunteer standards. So we really appreciate and depend on all these volunteers. Next slide, please. And in case you were wondering, we do have these events coming up. The Women's Health Fair on February 24th at the hospital, mostly down the old Med-Surg corridor. The Friends Golf Classic scheduled for June 28th. The Ride to Survive in early September, and the gala is usually the first weekend in November. Watch for details. Next slide, please. All right, now's the time. Almost a little under. Yes, sir.
If you don't mind, I'm going to brag on the hospital for a second. My name is Brock Gibson. You may know me. I know some of you guys. We just opened the Beacon in the tavern down in St. John, where St. Barres, and which, by the way, we met with the Concord guys this morning about the sidewalks right there. So we're going to do our part with the sidewalks too.
Very good.
I just wanted to let you know that my primary responsibility, my primary career is in rural healthcare. And I've been in this space for about 15 years, and I have traveled to probably close to a couple hundred critical access hospitals, just like St. Genevieve. And, well, not exactly just like St. Genevieve, but, and that's my point I'm making, is that this hospital is uniquely high quality. And I know this firsthand because I work as a consultant in critical access hospitals, just like this one. I've never had to do any work in this hospital because they do a very good job. And you know, the rural hospitals face some very serious challenges. And you know, I'm working on a hospital in Colorado right now that's facing closure, and it's a tough gig. And for this hospital to do what they do here in this town is very impressive. I mean, it's very impressive. And I'm not just saying that. I'm telling you that because that's a fact. I have visited many of these hospitals. And it is a very difficult thing to do to manage a critical access hospital because of their reimbursement that he was talking about with Medicare, because they're cost-based, so it's a challenge to do that. It's one of those weird scenarios where a typical business, when they decrease their expenses, that would be like, you know, you're trying to create some margin. In a critical access hospital, when you decrease your expenses, you decrease your reimbursement. So it's a very difficult balance to be able to manage something like this. And so this hospital is beyond, it's probably out of the 150 to 200 hospitals I visited, they're in the top 3 that I've been in. And I was born in this hospital. I'm local. I'm born and raised here. But you know, so there's a little bit of bias there. But the fact is, you know, the building speaks volumes. You know, they said 40% of critical access hospitals operate in the red. That's a fact. In my experience, it's higher than that. But it's very common, but it's we've got a really great town and a really great hospital supporting that town. So I just wanted you guys to know that from my perspective. Thank you.
Thank you.
Yes, ma'am. Question. This shows that we will now have 2 women's wellness clinics, one here and one in...
Well, Dr. Bakepore is already in Bloomsdale. So we have 2 women's wellness clinics now.
Where's the one besides them?
It's in the lower floor of the hospital. So do you know where cardiac rehab is?
Mm-hmm.
Okay, as you're coming in to go, if you come into that door where cardiac rehab is, you turn into cardiac rehab. If you continue on straight, that's where Dr. Kurtz and Kelly Donzi and Brittany Trillian are.
So we're still going to have the one that lives there?
Yes.
The same people there than there now?
Yes. Yes, ma'am.
Kind of a question about possibly how they take over. I mean, the larger companies or hospitals, do they come in and do they find weaknesses and come in and infiltrate, if you want to use that terminology? Are other hospitals, are their beds weaker and they get in, or a doctor that might be dissatisfied that helps them push their way in?
There are a number of ways it happens. The most common way, and I've been on both ends of the affiliation discussion. I've worked in big systems, I've worked in small systems, I've worked in larger independent hospitals, and I've worked in other small hospitals like this. Most commonly, the hospital has some kind of financial difficulty. If a big business leaves town, or if the insurance contract changes, or if the town is just diminishing in size and all you have is Medicare patients, then it's tougher to make that bottom line in that circumstance than in other circumstances. Usually there's a slow decline and they get to a point where they're not really sustainable on the model they had before. And if some hospitals close altogether, some hospitals will close down their inpatient care. Others, I'm talking with the hospital in Salem, Missouri. I came across the administrator there. I'm talking with him. They came across a lot of financial difficulties. They have a census about like ours. They have a lot of similar circumstances, but they just hit the skids. And so they're closing down services. So they may close down services like they close down their home health and their outpatient infusion and their dialysis, and they're going to try and maintain their core inpatient. And at some point, they kind of lose the grip, and they can't maintain the inpatient because they don't have enough other things going on to fund the 24-hour operations of a very small inpatient load. And so then they have to go looking for help. The help can come in a number of different ways. And I've worked in all these different, I've worked in managed, leased, owned facilities of bigger systems before. So it could be that they come in and they buy the hospital outright. It could be that they just lease the operations and leave the building to the county, kind of like they're doing in Paragon. It could be that they have a manager who is the CEO or maybe the CEO and CFO or senior administrators, and then they try and correct them, give them guidance and opportunity for insurance contracts and purchasing contracts so that they can get some efficiencies and try and maintain independence that way. So there's 5 or 10 different ways that can develop that you can't make it on your own, and you need some level of support beyond that. And right now, we're maintaining without that, and that is the goal.
So our strength is in numbers. And everything you said this evening about productivity and stuff, that maybe keeps moving.
The more people come here, the less reason there is, the less opportunity there is for someone else to say, we just need to own you.
Thank you.
Yeah, good question. Yes,
Quick
ma'am.
question. I know Representative Smith was here, and I know you spoke with him. Does he feel that there's going to be any help for the rural hospitals? I know he's probably pushing towards that, but is there anything on the forefront?
The things that they're looking at include changing the 340B, the pharmaceutical program that I talked about. That would help some. The thing that Congress has put out most recently is called the Rural Emergency Hospital. So that goes towards hospitals that have less volume than ours. So you look out towards Fredericktown or smaller hospitals like that, where you may only have a census of 1 or 2. You may only have 3 or 4 doctors in town total. And if they're opening up funding to keep those viable, but then they can't do surgeries, they can't do babies, and they have to they don't keep people overnight. So that really wouldn't help us with that, and that's the most recent fix that Congress has brought forward in terms of small rural hospitals. I think that designation will probably change over time. I won't get into minutia, but I've seen them start with a model and then change it once they figure out it doesn't quite work. But none of those things are going to really help us a whole lot. So right now, I've got an opportunity to go to Washington in a couple of weeks and meet with his staff. As part of National Rural Health Association, I'm on a national policy development board for them. And so that means I get to go in and talk to my representative. They really want me to go because our representative is chairman of the Ways and Means Committee who decides how the money is spent. And so last year I went in and gave the staff an earful, and this year I'm going to go in and give his staff an earful again if he's not available to meet with me himself. So we're going to keep advocating for increasing the funding for critical access hospitals. There have been some takeaways over the years that 1 or 2% of Medicare money is a really big deal for our hospital. And so when they take that back and say, you know, we're going to monitor quality and give it back to some of you and not to others, that's really not going to help us because we have those fixed expenses. We've got those labor and delivery nurses 24 hours a day, and they're getting more expensive. God love them. I want them there, but it's costing more every year. And so we need the insurance companies and the feds to pay some of the cost of doing that because we don't have another source for it. Other questions?
Can I add to that about the labor and delivery thing for a second, though? So when you mentioned earlier about how rural hospitals don't have this, it's uncommon to have labor and delivery in a critical access. Very, very uncommon. I mean, it's probably 1 in 20 hospitals. That's just a number I'm making up off my head of my experience, but it's very uncommon. And the reason it's uncommon is because in a rural hospital, Medicare reimburses based on cost, right? Well, OB does not qualify as cost because Medicare patients don't have babies, right? So in a critical access hospital, having OB labor delivery is a very rare treat because it is an expense that is not reimbursed by Medicare. So we have to, you know, there's a lot of cost and a lot of expense that goes into that is not reimbursable by Medicare and does not go into the cost of their the way they calculate their reimbursement. So having a labor and delivery in a critical access hospital is rare and is a sign of a high quality facility.
Other questions? Other comments? Okay, well, we may get you down to Danville or wherever else you're headed at a good time tonight. And thank you for your time this evening. We want to make sure that you have some information about your hospital so that you know the way you can make a good choice. We're going to have another session next Thursday, same time, same place. You don't have to come if you want. And we'll see you all then. Thank you very much.